to talk about the ear canal. It's on chapter 7, page 79. I will try to stay in the box, Ricky. All right. But I had to move this over. We got about 20 articles here, easily doable in 30 minutes to talk about what's said about the ear canal. At the beginning of the chapter, I put this one together for this manual. There's some, I always find it entertaining when you're going to do something, particularly a topic like this, which has a fair amount of anatomic basis to it, to actually review some of the pertinent anatomy that's clinically relevant. Remember when you took anatomy as a student, you memorized all this shit and it was like there was no value to it. You had no idea what was important. Then you go to doctor and you're like, oh yeah, I can't remember any of that anymore. So I look back at it, and there's a lot of pertinent stuff about the ear in terms of the canal's location. It's very close to the facial nerve. It's very close to the carotids. It's very close to the cavernous sinus. And some people, there's a fair amount of anatomic variation in spite of all those important things being nearby. One of the interesting anatomic variations is that some people lack a bony cortex over some of their mastoid air cells or over some of the portions of the canal, which means that person is particularly prone, for example, for direct contiguous spread of infection and meningitis. Anyway, the anatomy is there for you to look at. It's a reminder of what's out there. In terms of ear canal problems, it's quite clear that the vast majority of presentations to an emergency room are really minor. It's otitis externa, it's otitis media, it's something caught in there, it's a furuncle at the entrance. It might even be a cholesteatoma, which could eventually need surgery, but it's not a pressing emergency now. Among the emergencies that are there, and there are a few, really malignant otitis externa is the single most impressive and important of those to never miss. So the elderly diabetic with a pseudomonal otitis externa is something you can't miss. Let's go and look at the articles. We're going to talk about swimmer's ear first, acute otitis externa. And before doing so, one of the things that is a marker of this manual and of this course over the years is that Rick kind of wants us to know a little bit more about costs and business. And it is true that, we don't pay much attention. If you ask doctors how much drugs cost, a lot of times we have no idea. And if you go to the red book, the pharmaceutical book, the AWP, the average wholesale price, it's also known by the pharmacists as AWP ain't what's paid, because the pharmaceutical industry jerry-rigs things up and down to suit their needs in marketing. Kind of on balance, though, if you talk about putting drops in the ear, it's worth knowing. Ciprodex, the brand name, $90 US for a round. That's pretty expensive. Cortisporin suspension and solution, both on brand, about $70. Generic neomycin, polymyxin, and steroid, they won't even tell you which one. It's just steroid, but it can be Dex, it can be other things. $17. So just from dropping to one to the generic, you can save $65. This might be very relevant, as you know, in the emergency room. We meet our EMTALA, unfunded obligations. And for some of our patients, $90 for eardrops just isn't happening, certainly where I work at the county hospital. And so being aware of the difference in the prices is important. The first paper asked a question which is equally relevant to me, which is better, the suspension or the solution? And I remember one of my faculty once making a fuss about this, and I was like, what's the fuss? It's the same stuff, suspension, solution, what's the big deal? It turns out that it's not the same stuff. I mean, it's obviously the same ingredients, but the suspension, which you need to shake before you put it in the ears to resuspend it, actually, if you look at abstract 1, and also they touch on it in abstract 2, has a much broader array of indications. In other words, it's not just indicated for otitis externa. You can use it if the TM's perf. You could use it for other canal pathology. And the suspension hurts less when it goes in, and it's more effective it beats the solution by a day. I mean, it's not a huge thing, but it beats the solution by about a day. And so the suspension turns out to be the clear winner for every indication. So this is like a simple no-brainer. If you look at this paper, it's very clear. You should never write for the otic solution. You should write for the otic suspension, and they need to shake it. The only place the suspension loses in the literature on the topic is if you want to look in the ear. If someone just put drops in the ear and you want to look in there, well, you can't see crap because it's a suspension. They got milk in their ear. You won't see anything. And so you have to remember that if someone's going to get a re-eval or they're going to go see an ENT and you've referred them, that they should be told not to put the drops in the ear the morning that they're going back to their doctor so that the doctor might see something. That's the only drawback that you can really find to the solution. Otherwise, the solution has broader indications, feels better, and works faster. Did I mess it up? Suspension. The suspension is the winner. Abstract 2 is one of these papers, and just as Jerry said, the literature can sometimes mislead you. And Abstract 2 is this weird paper by some chair of, I forget where, ENT somewhere else, who recommends creams more than drops for the ears. Now that's kind of like taking the suspension to the next level up. The only problem is I don't know how you get the cream in the ear. If you remember the old grandmother's recommendation, never put anything smaller than your elbow in your ear. I don't know how you get the cream in there, and I don't see these taken off, but there's your recommendation. The reason the article's primarily there is because it's one of the abstracts that makes a quick address to what's in the ear, what grows out when you actually culture it. It's about 60, for Otitis externa, it's about 60 to 65% Pseudomonas. So whatever you give needs to cover Pseudomonas. It's about 15% staph, and I've been seeing, with the MRSA thing that's going on these days, I've been seeing some auricular furuncles right at the entrance to the ear. It's one of those things when, as you get older, you have hair where you don't want it and don't have it on your head. One of the places you can get it is in coming out of your ears in a bushy way, and you can get furuncles there. And those can be staph. And 5% in that series were Proteus. Now, when I was a medical student, if someone had just told me this, I can remember as a third-year medical student, you're on rounds with your little coat to here, trying to not look like you should be asked the question. The Socratic method when you were a third-year medical student was like the biggest hunk of crap on the planet. You were like, yeah, I haven't slept at all. I've been up all night checking I's and O's, and now we're going to do the Socratic method. Leave me alone. But anyway, I remember that, and they would always get to these questions. Now, what bacteria? You're like, oh, Jesus. Microbiology wasn't bad enough. Now I'm supposed to know the bug, and the next thing they're going to ask me is the damn drug. That's, it was like bugs and drugs on rounds again. It's like stump the chump, I'm the chump. I'm a third-year medical student, I know nothing. And if someone had just said this, if there's plastic and rubber involved, it'll be Pseudomonas. If there's fabric or cloth involved, it will be staph. It really would have helped me. So in the ear, swimmer's ear. Well, pools are made of plastic and tile, and they got rubber junctions. It's going to be Pseudomonas. You got a hot tub folliculitis. Well, it's plastic and rubber. It's going to be Pseudomonas. You get a nail through your sneaker. That's rubber. It's going to be Pseudomonas. You're in the ICU, intubated with plastic in your throat. It's going to be Pseudomonas. You got a Foley catheter in. That's rubber. It's going to be Pseudomonas. If it's rubber or plastic, it's going to grow Pseudomonas. If it's cotton or fabric, it's going to grow staph. You leave a tampon in for 3 months, it's going to be staph. You pack your nose and it overgrows, it's going to be staph. You get a gunshot wound through your flannel shirt, it's going to be staph. And so that helps a little bit, and that's why Pseudomonas is particularly swimmer's ear. If you think about your bathroom and hot tubs and pools, there's a lot of rubber and plastic around, and it will be Pseudomonas frequently. Now, the water is a key feature with the development of Otitis externa, and I'm always fascinated. If you read these papers, some of them say some weird things that can't be true. They describe the wax as hydrophilic. Some of them. A lot of them, in fact. How can wax be hydrophilic? I was pretty sure oil and water don't mix. So the wax is actually, I think, hydrophobic. It actually, though, what it does is it decreases the size of the canal so that the meniscus tension of the water locks it in and your ear doesn't drain. But to call wax hydrophilic can't be right. You might call it hygroscopic, but not hydrophilic. And what happens is once that water gets there, there's maceration, then the Pseudomonas overgrows as the tissue breaks down under the effects of the water. Abstract 3, fun study, double-blinded Dutch study that compared some of the other simple remedies. You might say, well, you reviewed the costs of the otic suspension. What about the other things that are out there, like acetic acid? And so this one looks at acetic acid plus steroid versus dexamethasone, neomycin, polymyxin, and acetic acid. And acetic acid alone, again, for otitis externa. And really what they came up with here is the concept of telling people to just use acetic acid alone, say they were broke and didn't want to spend even the $17. It's probably not a good idea, and they recommended against it. It had the longest healing time, but more important, there was a 45% recurrence rate. The recurrence rate with acetic acid alone in this paper is kind of a reason to think, yeah, great. If you were out in the country and it was all you had, you might use it. But if we can do better than that. And then finally, whenever dealing with otitis externa, all these papers, if you get the original manuscripts, would emphasize you got to talk to the patient about dry ear precautions, not putting stuff in their ear, not macerating and injuring the canal, and that those precautions are as important in the resolution of this as anything else. And once someone has swimmer's ear, this tendency for them to get it again you can talk to any child who grew up around a pool, and they'll tell you if they get it early in the summer, they have it off and on all summer long. So you really need to tell people to really let it resolve. Yes, you're taking the drops for a week and you feel better, but that doesn't mean it's done. They probably need another 10 days of dry ear precautions after the course of the drops. Now, is there ototoxicity issues? We're talking about putting things like neomycin in the ear. Is that an ototoxic component? Well, yes, it is. It's related to gentamicin. And how big a risk is this? We worry about it. And one of the things is that when we have a little worry about something like that, if there's another new drug that the drug company can tell you doesn't have that same risk, they'll capitalize on your fear and try and get you to prescribe the new, more expensive item. For example, they might try to get you to prescribe a fluoroquinolone, which doesn't have the same ototoxicity. So it's true, if you wanted to compare the three things, efficacy, cost, and ototoxicity, in terms of efficacy, you will be told by the drug companies that fluoroquinolones are superior. They are not. Fluoroquinolones equal aminoglycosides on balance if you look at the good literature on the topic. For cost, fluoroquinolones are way more expensive than aminoglycosides, no question about that, tenfold in some cases. For ototoxicity, fluoroquinolones are less likely to cause it than aminoglycosides. But to factor that in, you have to kind of know something about the ototoxicity. How real is the risk? Should you really be writing for fluoroquinolones because you know it covers Pseudomonas and you're worried? Probably not. You probably ought to be writing for the cheap stuff more often. There are some times when you might consider the fluoroquinolone, and what the bulk of these papers, and 4 and 5 talk about this, what the bulk of them say is that if the TM is intact, then ototoxicity is a vanishingly small possibility. If the tympanic membrane is ruptured and you're going to bathe the middle ear with the drops, and if you're entertaining a longer course because they've had a chronic process, that's when ototoxicity becomes a real issue. But even when it becomes a real issue, the rate of it is still extraordinarily low. In abstract 5, best estimate, 1 in 10,000 cases. Now, having noted that, there are 2 rules of case reports. Jerry, I'm going to steal from Jerry, but Jerry's rule of a case report is you would never read a case report because a case report is about something that will never happen to you. The reason the case report got published is because it was so rare it had never been published before. The fact that it happened to someone else means that a really rare event just happened. It will never happen again. If you go to Vegas and are checking the odds, the fact that it happened to them means it will never happen to you. And so you wouldn't read it. Now, that's true in a lot of things, but sometimes case reports find new things or identify patterns that are emerging, and then they can be very important. And sometimes if the question is, does blank ever happen, and you have a good case of it where the causality looks good, then a single case report can answer the question unambiguously. Yes, blank happens. And so if the question here is, does ototoxicity ever happen? Is it a theoretical fear? Then abstract 5, which is a 5-patient series, all the patients had a TM deficit. All of them were being followed by an ENT. They had a longer course of an aminoglycoside. And what they ended up with in these 5 patients was sensory and neural deafness, severe vertigo, so bad they couldn't walk. Well, now that's ugly. If that was a real concern, it would be a compelling reason to write for fluoroquinolone on every person with an ear problem. But you have to kind of know what the baseline is, and we think, no one really knows the real number, but it's less than 1 in 10,000 or around 1 in 10,000 cases. And the salient take-home point is if the eardrum is perfed, fine, right, for the fluoroquinolone. You can justify the expense. If the eardrum's intact, it's a first-time event, you're talking about a 5 to 7 day course, right, for the cheap stuff. Abstract 6 is a big paper on diabetes overall. You might wonder what it's doing in the otitis, externa, ear canal kind of segment, but I had to put it in there because we don't really have a lot on malignant otitis externa. As you might imagine, it's kind of a hard thing to study. It doesn't happen often. It's on every board exam. It's a devastating disease which requires admission to usually a critical care unit. They're usually in DKA in conjunction with this, and surgical consultation. But I include abstract 6 because abstract 6 is it's a huge manuscript. It's a broad descriptive paper that talks about diabetic infections in general. And what it reminds you is of a really important thing with diabetic infections. If it's not a cellulitis, but in fact it's a neck fash, that's different. If it's not a scrotal edema, but in fact it's Fournier's, that's different. If it's not just otitis externa, but is in fact malignant otitis externa, that's different. And you could keep on going down the list. If it's not just biliary colic, it's actually gangrenous cholecystitis with ascending cholangitis, that's different. All of the different items that I listed there are diseases, infectious diseases, associated with diabetes, where for the patient to survive the event, they must meet men with knife. Men with knife must come see patient early in course. Men with knife should not be trusted to admit patient. Man with knife is technician, really. They need a doctor, they need an intensivist to manage them, but a surgical event has to happen early in their course or they will die. And malignant otitis is like that. How about getting the wax out of the ear? Should we spend a lot of time, gouging around in there, getting the wax out? You got to see the TM. It's a pressing need. How pressing is the need? Rick would tell you, please, it's not a very pressing need. Do not spend a lot of, yes, it's a billable procedure on a level 3 case, but please do not spend a lot of time gouging around. The vast majority of the time, it's irrelevant. He would argue, first of all, that the fever is not caused by the otitis media anyway. The fever is caused by the concomitant URI, which you really can't see when you get the wax out. The concomitant URI is by, asking them a history, and you get more or less the story that I have this morning, which is constant effluent, full head, and a cough. That kind of thing. But it's not, you don't need to get the wax out. And then people have said, well, if they have otitis media, the temperature from the otitis media, the temperature rise, will melt the wax and it will flow out. It's a lovely story. I really love that story. I just wish it were true. It isn't true. We know it isn't true for a couple of reasons. One of the best reasons we know it isn't true is if you have, like at my hospital, we have the 13th floor. Someone's idea of a joke, that's where the jail ward is. And on the 13th floor, there are various and sundry drug abusers, gang members, et cetera, miscreants, alcoholics, et cetera, the usual problems that you see in a jail. And among them, every once in a while, you'll see ear foreign bodies. And if you take, we take a lot of cockroaches out of ears. We'll talk about that in a moment, things like that. And every once in a while, you pull a little black thing out, and you look at it, and the first time this happened to me, I was like, what the hell is that? I don't know what that is. And I looked at it, and the second time it happened to me, I was like, I know what that is. That's the stopper to a TB syringe. The plunger has a little rubber thing on the end. That's what that is. And so then, and the third time I saw it, I was up on jail, and the jail people, once they're arrested, they pretty much will tell you anything you want to know about their business and life and what it's like to be a gang member or a drug abuser. So I asked the guy, hey, how did this get in there? It's a stopper. He says, yeah, well, he says, when you got the belt around your arm and you're pulling it like this and the veins are up and you just stole 5 radios to buy some heroin and you can't get good syringes because there's no syringe program in LA and you got that there and you draw the heroin up through the cotton ball and the little flame, the Bunsen burner or your lighter, and you get the syringe full of that hot heroin and you're letting it kind of cool off a little bit and you're going to inject it and you go to put the plunger down and it's cracked and old because you can't get a new syringe and your heroin leaks out around the plunger. He goes, that'll really piss you off. I said, yeah, what's it doing in your ear? He says, well, you need a way to make it not leak. You need a non-allergenic bioocclusive sealant that will survive through the heat of the heroin. I said, and? He goes, and earwax is that. So they take the stoppers out of their syringes, put them in their ear, harvest some cerumen, and then they can inject their heroin without it having leak. Which points out, it's an interesting story. One, it points out why you'll see syringe tops in people's ears. And two, if the wax can be used with a hot heroin, drawn up, it's clear that otitis media is not melting your wax in your ear. If the hot heroin isn't melting it, your otitis media isn't. There's some papers here that talk about this. 8 is an important paper. When you're thinking that I need to gouge the earwax out of the ear, look at abstract 8. It points out that if you do nothing, they come in with a lot of wax. When will it be gone? Well, on average, for a quart of them, it'll be gone in 5 days. You did nothing. So nothing's not a bad option. If you use cerumenol, it'll be out in 38% will be out in 5 days. If you use water, 32%. If you use bicarb, 26%. So they said that solvents, particularly water-based solvents, don't work. Why would that be? Because water and oil don't mix. As we said, it can't be hydrophilic. So then we know that we have these products, the murine, earwax, and the Cerumenex. How well do they work? You'll love abstract 9. One of them made it 29% clear, one made it 15% clear. But the best part of abstract 9 is those 2 products did worse than placebo. Placebo got half the ears clear in the same time that Ciprodex got a quarter of them clear. Again, a reminder that you need to gouge around in the ear. Now, when you look at the ear, remember, the older the wax is, the darker it is. So if it's black, it's been in there for a long time. And some people, you'll actually see people who can't hear. You know, they got bilateral, and those are going to have to go. And so the question is, how should you make them go? And the answer is solvents are better than gouging around. First, you should loosen it up. What's the best solvent? Well, it's basic chemistry, like dissolves like. Hence, wax can't be hydrophilic. So what solution is like wax? Well, it turns out colace. Please don't confuse this with my later talk to follow, rectal mist, but the colace liquid, if you break the gel caps or if you have the liquid colace for kids and you get a syringe full of it and drip that into the ear and let them sit with a warm compress there, colace is the best. In Abstract 10 by Adam Singer, who works in Long Island, he's a big researcher in emergency medicine, proved really convincingly that colace is the material of choice by far when compared to others. By far. It worked way better. 11 reminds you that there's no teeth in the ear canal. That's important to know. If you see an incisor in the ear canal, you probably ought to refer that to a vet because humans do not have teeth in their ear canals. Why do I mention this? Is that you shouldn't be using a water pick to remove wax. This is one paper, and I know of several now, there are about 3 of them, that water picks create enough pressure to perf TMs, pretty well documented. So as long as you're just macerating the ear canal with the water pick, that will just hurt and not cause a huge problem. But if you actually hit the TM with it, you can perf them. So no water pick in the ear. If you're going to inject solution, it should be at least warm so they don't get that. Remember the cows, cold opposite, warm same, nystagmus. Putting ice cold water into someone's ear is bound to ding, 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 you're going to have some nystagmus and they might barf on you. So make sure if you're going to irrigate an ear, you do it gently with a soft tip syringe, and that's a fine way to go. But no water picks. And Abstract 12 is a funky paper worth reading, entertaining. I'm not sure I wanted to read it. It's a paper by lawyers that says, hey, doctor, did you consent that kid to get the wax out? Like, no, I'm gouging the wax out. You know, what do we talk about consent? They said, well, and this lawyer goes through and says there are actually a fair number of cases where somebody's going after the earwax on a kid, and the little bastard won't hold still, and he's squirming around, and suddenly the little ear loop has not only perfed the TM, but when you pull it out, there's wax and a stapes there, which is not so good. So ossicle disruption, TM rupture, deafness resulting from people needlessly going after wax, which is just more fire, more fuel on Rick's fire, which is why would you do this? And so these lawyers say you really ought to consent people and let them know that if they do nothing, the wax will be gone in 5 days. And if you gouge it out, the wax will be gone immediately, but your kid might be deaf forever on that ear if I pull out the stapes. And so they say you should consent people. I put that there not because I believe that there's a lot of force in the paper as it's written, but it's interesting to think about in terms of reminding you that doing nothing. Remember the House of God? I don't know how many of you read it. It's a long time ago now. But in the House of God, one of my favorite lines is, the art of medicine is doing as much of nothing as humanly possible and taking credit for the cure. And it appears that with regards to cerumen impaction, that's an excellent strategy. Anyway, so 13 says that the heat won't melt the earwax, just as I said, that neither the presence or the cerumen nor its absence is sensitive or specific for otitis media. 14 says that earwax does decrease as otitis media goes up, but it's not really enough to get you off the hook. Foreign bodies out of the ear. I just talked about one. How do you get them out? And it turns out that the ear is generally easier than the nose. Sorry, I said that backwards. The ear is generally harder than the nose. The nose is easier. The ear, it's a sort of a S-shaped curve, which has a little hollow in the bottom, and foreign bodies tend to lodge deep in the ear right against the TM where you don't want to grab them. And so what does the literature say about foreign body removal? Well, it says a couple of things. It says cockroaches are pretty common. You know, if you're sleeping on a cracked mattress on the floor and the cockroaches are hungry, they will go in looking for some earwax. And they're really good about finding crevices. That's number one. Number two, it says that there are a variety of tricks. If you look at these papers, 15 through 18, alligator forceps work good. A suction tip catheter, a Fraser suction tip works good. Sometimes people talk about using crazy glue. I'm not that wild about that approach. I don't think it works well. But there's a variety of tricks of the trade. But whatever tricks of the trade you employ, and I'm sure everyone in here, if I was to query you all, you're all familiar with these things. So you can't actually work in an emergency room without having become quite familiar with foreign bodies lodged in various places. But what these papers all say, which is an important conclusion, how do these papers add to your practice, is they say this. They say, make your best attempt. If you have to give the kid ketamine or conscious sedation to get them still, do so. Make your best attempt. If your best attempt fails, don't get stubborn. It's the stubborn. You know, there are places we know as our specialty, we pride ourselves on being self-reliant. You know, we don't like to call consultants, one, because they don't like to be called, and many of them wake up ugly. But two, we don't like to call them because the patient came to see a doctor, we're that doctor, and we like to handle most of their problems because that's a gratifying way to work. And so we do have a little bit of stubbornness in us. It's a good thing in general. But these papers say clearly, if your first attempt fails, raise the white flag of surrender. And the ENTs that looked at this stuff say, listen, when the ER doc can't get it, increased attempts results in increased perforations, increased infections, increased problems. And when the ENTs went to get it, when we can't get it, it actually is hard. They need microscopy, they need special tools. And so they have more widgets and gadgets for this. They have more surgical tools. They have magnification. And so if you can't get it, stop, is what these papers say. All of you know how to do it. If you can't get it, stop. And 18 looks at this question, nose versus ear. It's a 2006 paper and says just what I tried to say in the beginning but said backwards, which is that the ears are harder. High failure rates with ears. ED success rate in this paper was 12% for ear foreign body. That's just too low. And most of the papers say that the success rate is somewhere between 50 and 75%. In other words, we get even most of the papers are clear. We get the majority of them out, but don't get stubborn if you can't get it. And the last two papers here and one of them got lost. 20 got lost in the printing somehow, but it says the same thing that 19 says. They asked the question, is your cell phone going to give you an acoustic neuroma and cause you a problem for the rest of your life? And maybe you're hoping that'll happen to your teenager who really seems attached to their cell phone. And both of the papers, and the 21 that got lost is by an author by the name of Inskip. If you're interested in the topic, it's in the New England Journal. And they both say that there's no real association with acoustic neuromas, either with laterality of phone use or with specific types. But both of them add the final caveat that because the technology of cell phones is changing and that the interval from exposure to the development of the acoustic neuroma to a point where it's clinically identifiable might be 20 years, which means since cell phones have really only been around and used by a lot of people for 10 years, we can't possibly know the answer just yet. So far, the magnitude of the effect, if there is one, is too small to be detected, is really what you can say safely through these papers. It doesn't look like there's an association or causality, but both authors caveat it by saying, we don't know because the lag might be 20 years. Questions, comments?
In my community, we've had to give oral antibiotics in addition to ear drops for Otitis, Externa, forever. And, but we don't get people better necessarily, or we have people who come in from their family doctors who have just an ear drop. Of course, we don't get everybody. I think that's treatment failure. We used to be able to use alboxytol, but over the last year, we have to go to on-venom. I wonder if anybody else has had addicts with it. It's for kids and all comers.
So I don't think it's a universal experience, I would say that. But what you are touching on is the question of if it's just a simple otitis externa, the drop should do it. If it's otitis externa with otitis media, in other words, it's had contiguous spread to the middle, and particularly when you describe the cases where they're chronic and it's been going on for a while and it's not getting better, sometimes that's the case. If they have a concomitant otitis media, the argument in favor of giving systemic antibiotic is a good one. Also, if the ear canal infection spreads from the ear canal outwards and they have a helix cellulitis, or they're tender in their actual ear itself, and they really have a facial or ear cellulitis in association with it, that also won't get better with the drops alone and is going to need antibiotics. So I think that you're right. Particularly among the chronic places, there can be a role for some systemic antibiotics to get it better. I personally, and just, not just personally, if I was to echo the literature here, they would say that in general, for a simple otitis externa, it shouldn't be necessary. Shouldn't. But if they have these other components, ear or media, then yes. Yep.
We just had a guy in with ear infection a couple days ago who went home on a
Yep.
perforated TMs running all over the place. What's the incidence of something like that?
Unusual, but certainly well known. If you look in the sinus literature, and Jerry's going to do, I think, are you doing sinusitis, not so simple? One of the things about sinusitis, not so simple, the chapter, is that unlike pharyngitis, where we really don't believe there are real suppurative complications of significance, with sinusitis and with otitis, if it's chronic, with both sinusitis and otitis, there are real suppurative complications. And those suppurative complications, I'm sure Jerry's going to touch on, include brain abscess, meningitis, contiguous spread. I mentioned at the start of this that some people don't have a cortex on the bone, and so they're at risk for contiguous spread. But the thing that comes out throughout that literature, and it's not great literature, it's case series and such, is that when you look at them, oftentimes there's an element of chronicity. So they've had it sort of better not, or delay. So chronicity and delay are things that you see repeatedly, and they may actually have some anatomic variances that make them susceptible. And I'll stop there.